espacio. Gracias por conectarse a este espacio que nos ofrece GESIGO en compañía de AstraZeneca. Hoy tenemos la compañía de la doctora Nicoleta Colombo. Ella es bastante conocida, ginecóloga, directora del Centro de Cáncer de Ovario del Instituto Europeo de Oncología, es autora de varias publicaciones de estudios en el campo de la oncología ginecológica, miembro de sociedades como ASCO, de la Sociedad de Oncólogos Ginecológicos y de la Sociedad Internacional de Cáncer Ginecológico IGSS. Entonces, doctora Nicoleta Colombo, welcome to this space. Thank you for your time and your talk. We are going to start with an ovarian cancer case, and then you're going to have the space with your conference. So this is my disclosures. The first clinical case is a 70-year-old woman without a history of past illness. She has no complaint. She complained with abdominal pain and right ovarian mass. Normal chest images were made, and the CA-125 was 1,200. By April 2022, the team of gynecology made a total abdominal hysterectomy, a bilateral salpingo-oophorectomy, and a montectomy. The pathology with the right ovarian tube, right ovary, and pelvic peritoneum found 19 centimeters of a high-grade serous carcinoma of the ovary with involvement of the ovarian capsule with extension to the tubal wall and lumen and to the pelvic peritoneum. Also, it has a disease in omentum, right paretocolic and subdiaphragmatic peritoneum, and para-aortic lymph nodes involvement. The cytology for washings were positive, and finally, a high-grade serous ovarian cancer stage 3C was made. For the adjuvant treatment, the oncology team gave her a carboplatin and paclitaxel for 6 cycles. For the middle of the treatment, like by 4th cycle, she had a grade 3 peripheral neuropathy, so the paclitaxel dose was reduced. She completed the chemotherapy in October 2022 with the tumor marker negative and images without disease. We received the somatic BRCA test with a positive for a pathogenic variant in the BRCA1 gene, and the germline test was negative. So she is part of this 10% of patients with a somatic BRCA1 or 2 mutation. With this finding, we start a maintenance with a PARP inhibitor with olaparib. She started this treatment in November 2022 in the SOLO-1 context. After 1 month of treatment, by December of 2022, she presented with a grade 3 anemia. Other causes of visitopenia and anemia were ruled out in that moment by hematology team. So we stopped the treatment 1 week and restarted with dose reduction. After 2 months of treatment, she presented with a grade 3 thrombocytopenia. So again, we have to stop the treatment 1 week and restarted with a second dose reduction. With that second reduction, the treatment was well tolerated, and finished the treatment with olaparib in November 2024. The CA-125 was negative, and the images were without relapse. So here we have some questions for Dr. Colombo. Maybe you want to answer this question now, or through your talk, we are going to have these answers. So the first question is, if this patient were positive HRD BRCA1 type, would you treat her with PARP inhibitor plus bevacizumab or only PARP inhibitor? The second question is, in which patients do you use PAOLA-1? Or do you use the Kelly score in any case to guide the treatment with bevacizumab? And in negative HRD, do you use PARP inhibitor, and in which cases?
Okay, thank you. A lot of questions. Okay, so the first, in case of HRD positive and BRCA wild type, so what is my treatment of choice? Yes, I do believe that in this case, the combination of bevacizumab and PARP inhibitor can give the best chance of benefit. Therefore, I usually consider when there is no, of course, contraindication for the use of bevacizumab, I would prefer to use the combination. This is because, as you know, and I will discuss during my presentation more in detail, we also have positive overall survival data for the population. And so for me, this is option that I can offer to patients with these characteristics. So Paula 1, I'm using Paula 1 in this population in the HRD positive and BRCA wild type. This is exactly the population where I'm using it, because for the BRCA mutant patients, of course, they are also HRD positive, but they are also BRCA. Actually, I have a limitation in my country that we can only use olaparib alone and not the combination. So that's why it's easy for me to choose. But of course, if I could, there are patients where I may consider to use a combination of, like in Paula 1, also in BRCA patients, in BRCA positive patients, particularly those with advanced disease, with stage 4 ascites and so on, when I like to use bevacizumab together with the chemo. And then, of course, after that, if they are BRCA mutants, I will like to add olaparib to bevacizumab. Kalim score, yes, I do. We do use Kalim score. And this is strictly related to the last question about the use of PARP inhibitor in HRD negative population. I use the Kaling score to decide that. So if I see that the Kaling score is extremely favorable, I may decide not to use bevacizumab, and if the response to platinum is very good, almost a complete remission or so on, only in this case, even in the presence of HRD negative test, I would consider to use PARP inhibitor alone. So the condition is a very, very good response to platinum, which is a very good predictive factor for response to PARP inhibitor. So in this case, I would consider PARP inhibitor alone. Otherwise, in the HRD negative population, I prefer to use bevacizumab. So if I don't achieve a very good optimal response to platinum, I prefer to add bevacizumab to chemo and then to continue with bevacizumab as a maintenance.
Thank you. I think you answered all of these questions. So I'm going to stop sharing my screen to...
Okay.
Ya estás ay.
Sigo compartiendo.
Okay. Can you see my screen now?
Yes,
Yes.
yes, doctor.
Okay. That's great. Okay, I don't know if there are any questions, but maybe at the end of my presentation, because some of the questions you posed are also discussed during my presentation. So maybe at the end, we can also go back and discuss further. So I've been asked to talk about the ESMO guidelines on the management of HRD positive, newly diagnosed advanced epithelial ovarian cancer. And these are my disclosures. So let me start by reminding all of you what is ovarian cancer. As you know, there are still over 300,000 new cases diagnosed worldwide. And unfortunately, most of them will be diagnosed at a very advanced stage, almost 60 to 70%. And the other important characteristic of this tumor is that the majority of patients will relapse despite a good clinical response to frontline chemotherapy. Nowadays, we observe an improvement in the 5-year overall survival, but yet only less than 50% of these patients will survive more than 5 years. And this is because this disease is really characterized by multiple relapses. And also the characteristic is that the time between the subsequent relapse will become shorter and shorter. So this is the typical natural history of this disease. A lot of relapses and the interval becoming shorter and shorter over time. So what does it mean? What is the interpretation of this? Is that once the disease relapses, it is largely incurable. Therefore, the first line treatment for advanced ovarian cancer is the optimal setting to achieve a potential cure. What I always say is that you have to play your cards at the beginning, because if you lose the first battle, you will lose the war. So it's important to reach the maximum during the frontline treatment of this disease if you want to be able to cure more patients. And why the disease comes back? Because even when you can observe a clinical complete remission, you know that in most cases there is still this minimal residual tumor. And if you don't do anything, this tumor will grow back and then you will have the relapse. But if you can use maintenance therapy, which is more than maintenance, because the goal is to eradicate the minimal residual tumor after frontline therapy. So if you can eradicate, of course, you will avoid the relapse and you will be able to cure more patients. So that's why during the past years, we spend a lot of time looking for the best maintenance therapy in ovarian cancer, because we want to increase the number of patients that can be cured in frontline. And you see here in the last 5, 6 years, we had incredible results. Starting from 2018, when we had the results of the SOLO-1 trial, demonstrated an unparalleled benefit in, at that time, progression-free survival for patients with BRCA mutation treated with olaparib. And then in the subsequent years, we also have the results of the other studies, including not only BRCA patients, but also all comers. And again, we observe positive results for the use of PARP inhibitor alone or in combination with bevacizumab in the overall population. So why this is important? Because as you know, ovarian cancer, we have been struggling for many years to try to find a target for ovarian cancer. It was not impossible. There is no one driver mutation that you can target. But what we can target for sure is what we call the homologous recombination deficiency. So this is a defect in one of the most important mechanism of DNA repair. And we know that more than 50% of patients with ovarian cancer will have a deficiency in the homologous recombination. And this is not only related to the mutation of BRCA1 and BRCA2, but also to the mutation of other genes, but also to other mechanisms which are not completely understood. And it is quite clear that patients with this homologous recombination deficiency may benefit from the treatment with a PARP inhibitors. Why? This, I'm sure that all of you knows very well the mechanism of action of PARP inhibitor, The mechanism is based on what we call synthetic lethality. So basically, you take advantage of one defect in the cells to kill the cells. So you block the PARP, and in this way, during the replication, double strand breaks will occur. And in cells where the homologous recombination is working well, the cells will be able to repair the double strand break, but in the cells with a deficiency in the homologous recombination, this will not be repaired, and so the cells will die. So based on this, all the trial was started. Now, looking at the ESMO guidelines, first of all, I must say that these ESMO guidelines are quite recent, but probably new updates are also needed in the near future. But what I want to point out that, as you can see, they take into consideration for sure the mutational status, so BRCA patients, and the HRD. So that means that all patients with ovarian cancer should undergo not only the BRCA testing, but also the HRD testing, because this will inform your frontline treatment. And as you can see, the guidelines are quite open, however, because in the BRCA1 mutated, you can use olaparib for 2 years or niraparib for 3 years, or the combination of olaparib and bevacizumab for 2 years. In the BRCA wild type, HRD positive, niraparib is allowed, or the combination of olaparib and bevacizumab. And finally, in the HRD negative, BRCA wild type, you can use bevacizumab or niraparib. So to tell the truth, they don't tell you exactly what to do. I mean, they give you several options. But of course, this is based on the fact that we do have several phase 3 trials which are positive. And so it's impossible so far. We don't have a direct comparison between single agent PARP inhibitor and the combination with bevacizumab. So it's not possible to choose straight away. But in our clinical practice, we have to make decisions. So we have to follow some rules in order to decide what to do. So I will try to tell you what I think and how I behave in my clinic in order to choose the best treatment for each patient. So let me start with the BRCA patient. The BRCA patient is easy. The first concept is that for sure, no question about that, they have to receive a PARP inhibitor in the maintenance setting. Why? Because all the studies in a very consistent way demonstrated an advantage for the maintenance with a PARP inhibitor in patients with BRCA mutation. So no question, all these patients should receive a BRCA, should receive, sorry. FaceTime video. I'm sorry, I apologize. All the patients should receive absolutely a PARP inhibitor. Now, which one? Well, this is something that can be related to what you believe is the best, possibly on the toxicity profile, because I don't think we do have evidence that one is better than the other. I will go back to the combination with bevacizumab, though, because this is the most important question that you may have. Now, if we move to the BRCA wild type HRD positive, so what we call with a high genomic instability score, then what you see that again, there is no question that the PARP inhibitor can provide a huge benefit in terms of progression-free survival. And this is true with niraparib, it is true with rucaparib, and it's true for PAOLA-1 with the combination. So a PARP inhibitor should be there. For patients with HRD negative, I'm not completely convinced. Actually, as I said, I tend not to use the PARP inhibitor, if not in very exceptional cases where there is an incredible response to platinum. Because the data are not convincing. In the PRIMA study, you have a very small benefit with the use of PARP inhibitor, namely niraparib. And the same is for the Athena study with rucaparib. There is no benefit in PAOLA-1 for the HRD negative population. So all these were the progression-free survival analysis data. But now, as you know, we do have also overall survival data, and overall survival data are very informative. We want our patient to live longer and to live better. This is, of course, our goal. And so let's see what the overall survival data are telling us. Let me start with Solo 1. Solo 1 is an incredible trial with a longer follow-up. And I want just to point out that this analysis, this overall survival analysis, is not the final analysis. Why? Because we didn't reach the maturity for the number of events for overall survival. These patients are living so long that it's difficult to achieve the number of events which were planned for the final analysis of overall survival. In any case, we thought it was important to perform an analysis on overall survival. This is a descriptive analysis, so it's not the final, with a very little alpha for this analysis, because we want to preserve the alpha for the final analysis of overall survival, which will occur maybe in 4 or 5 years. And so anyhow, this descriptive analysis was done with a 7-year follow-up. So that means the last patient in the study had at least 7-year follow-up, so very, very long follow-up. And what we saw was very nice because you see incredible divergence of the curves, even in the later part, with 7 years, 67% of patients alive in the olaparib arm compared to 46% in the placebo arm. And this is true despite the fact 44% of patients in the placebo received subsequent PARP inhibitor therapy at time of subsequent relapse. So despite that, you see an overall survival benefit. This is very, very important to observe. And even more for me, because of course this means that the patients are alive, but they may be alive with tumor or without tumor. So it's important to look at the time to first subsequent treatment. If you look at 7 years, we have 45% of patients who, after 7 years, did not receive any subsequent treatment. That means they never relapsed. And this is 45% for olaparib compared to 20% for the placebo. Now, I don't know you, but if a patient comes in my office after 7 years without relapse and she asking, am I cured? I would say, probably you are cured. So that means that you have the possibility to cure 45% of patients compared to 20% without olaparib. So, and this for me is the main message that you can get from this very, very important descriptive analysis of overall survival. But let's go to the Paula one. We have the final overall survival because according to the statistical plan, the time was mature to perform the final analysis of overall survival. Remember, Paula 1 included all comers without any distinction in terms of BRCA patients, HRD, or clinical characteristics. So this is really an all-comer population. And of course, you have much more events because compared to Solo 1, where there were only BRCA patients. And this is the final analysis. And what is the final analysis? Okay, so if you look at the overall population, again, overall means everything. I mean, the patient who come in your office every day. You don't see improvement in overall survival. So hazard ratio 0.92, but of course there is no statistically significance. But if you look at the overall survival in the HRD positive subgroup, then you see a benefit, a clear benefit with a median overall survival of 75 months compared to 57. And the 5-year overall survival rate is 65% compared to 48%. And this is true despite the fact almost 51% of patients in the olaparib plus bevacizumab arm received a PARP inhibitor in subsequent lines. So despite a very high crossover, you see an overall survival advantage, and this is absolutely important. And again, as I said before, if you look at the 5 years PFS, so that means patients without relapse at 5 years, you have here 46% compared to 19%. Again, I think some of these patients may be cured. So that's an extremely important message, with a 59% reduction in the risk of disease progression or death for olaparib plus bevacizumab versus bevacizumab alone. I want just to report also this Chinese trial, even though this is a completely Chinese population with niraparib, and is the PRIME trial. And again, you see a benefit in progression-free survival, but not in overall survival. And as you know, we recently had the update from Antonio Gonzalez on the PRIMA data. PRIMA, as you remember, has met its primary endpoint for progression-free survival. And at this long-term follow-up, this was confirmed. So in terms of progression-free survival, you see a benefit for the use of niraparib in the overall population, in the HRD population, and also very small in the HRD negative population, less than 2 months, but you know, it's still statistically significant. But if you look, and this is the most important part, at the overall survival, unfortunately, the trial did not show any benefit in overall survival in overall population, but not even in the HRD positive population, not in the HRD negative, and not even the BRCA patients. They put the curves of the BRCA patients in the supplementary material in the paper, but are there. And you will see that even in the BRCA patients, there is no improvement in overall survival. This was very, very disappointing. Of course, is also very difficult to understand why, and we are struggling, and we try to find a reason for this. It is the drug itself, it is the population, which was different, the ethnicity, the subsequent use of PARP inhibitor doesn't look like, because as you see also in PALA-1 and SOLO-1, there was a very high crossover, and despite that, the overall survival was positive. The study design, the risk profile, the treatment duration. I think we can do what you want, and you can search and try to explain, but we do randomized trial because we want to have the closest as possible to the truth in terms of results. So we have to trust randomized trial and what they tell us. So whatever the reason, I think if we trust the results of prospective randomized phase 3 trial, the reality is that niraparib did not improve overall survival. And this is what we should believe. Now, let me spend now the rest of my time to go a little bit deeper in the choice between the single agent and the combination. Because as you have seen earlier, the guidelines leave you the option to use in many situations PARP inhibitor alone or the combination with bevacizumab. So how to choose? I think there are several questions, several factors that you may consider. First of all, the biomarker for sure. Maybe the surgery-related characteristics, maybe the label restriction, the response to chemotherapy, which for me is very important, and the toxicity and the contraindication. And let me start with the biomarkers. As I said before, there is no question that the patient with BRCA mutation or the tumor, which are HRD positive, must receive a PARP inhibitor as a maintenance. So the PARP inhibitor is there. It is also clear that the benefit is greater in the BRCA patients, then becomes still very important, but a little bit less in the BRCA wild type HRD positive, but is still there. Is more controversial, as I said, in the HRD negative population. So there is this gradient in the efficacy for the PARP inhibitor. Now, let me start with the patient with BRCA mutation. Should we add, so no question, PARP inhibitor should be there. But should we also add bevacizumab or not? That's the main question. Should we do we need bevacizumab? As I said, we don't have any direct comparison, so we do not have a randomized trial comparing single agent versus the combination. So we cannot be sure about the answer. The only thing we have is a kind of indirect comparison. This paper published by the Ignace Vergote in 2021 try to select patients in Paula 1 similar to the patient in Solo 1, so BRCA mutants with similar characteristics, and using a propensity score, they try to compare. And what you see that probably there is an additive effect of bevacizumab to olaparib. So it's not synergistic as we were hoping probably, but it looks like there is at least an additive effect of bevacizumab over olaparib or olaparib over bevacizumab. So one may say, okay, I'm going to use the combination also in the BRCA patients. But again, this is not completely strong evidence. Maybe in patients with bulky disease, ascites, where you need the bevacizumab even during chemotherapy to achieve a better response, maybe this is the case where you want to use the combination in BRCA patients. But let me focus on the most important patient, the patient with HRD positive tumor. And here again, should we add bevacizumab to PARP inhibitor or not? And let me go through some of the factors that you may consider. First of all, the overall survival data. As I said before, we do have evidence now for overall survival benefit with the combination of bevacizumab plus olaparib in this population. And despite the high crossover, so despite 52% of subsequent use of PARP inhibitor, for me, this is a very important message if I have to decide. So it looks like in this population, the combination of bevacizumab and olaparib can provide really a great benefit, not only in progression-free survival, but also in overall survival. And so this for me is a quite important evidence for the benefit of this combination, even in the HRD positive excluding BRCA patients. Don't look, of course, at the overlapping, but the important factor is the hazard ratio is below, far below 1 is 0.71, so there is a clear trend. The numbers are small, so you cannot, there is no statistical power to show really a statistical significance, but it is quite clear that even in this population, you see a benefit in overall survival. So for me, this is quite convincing in order to decide what to do in this population. Now, what else? I said survival data is important. Let's look at the clinical characteristics, because you may say, well, I prefer to use bevacizumab, as I said before, for the BRCA patients. In patients with ascites, bulky disease, a lot of tumors, maybe in this case, I prefer to use the combination. But is this true? I mean, it's true that bevacizumab can give you a benefit in patients with advanced disease, no question. But is it true that bevacizumab cannot give you a benefit also in the patients with no residual tumor after surgery? So you operate, you achieve the optimal disease status, so no residual tumor. Is that true that the combination of bevacizumab or olaparib is not working in this population? Well, we do have this subgroup analysis in the Paula 1. These are the HRD positive population. And what you see here on the left are the higher risk HRD positive. So that means patients with stage 4 or residual tumor after primary debulking surgery or undergoing neoadjuvant chemotherapy. And of course, you see the benefit of the combination of olaparib and bevacizumab compared to bevacizumab alone. And it's a great benefit with a hazard ratio 0.39. But you see also really outperforming of the combination of olaparib and bevacizumab in the lower risk. That means patients stage 3 after primary debulking surgery with no residual tumor. So you see that this combination performed extremely well in this population, and very well compared to the bevacizumab alone. So of course it is olaparib here, which gives the big advantage. But overall, together, you see beautiful results also in this population. So we don't have the comparison with olaparib alone. I recognize that. I appreciate that. But in any case, this I think is really an exception, is outstanding results that you can achieve in this population. Response to chemo. I mentioned that for me this is very important in order to decide to use PARP inhibitor alone. Why? Because if you remember the PRIMA study, they included a very highly selective population. These were patients with poor characteristics. Stage 3 with residual tumor, stage 4 neoadjuvant chemo. But despite the fact they started the chemo with very poor prognostic factors, they had to achieve almost complete response, a very good partial remission after chemo. That means small residual tumor, hormone, almost normal CA125. So they were extremely good responders to platinum. And as you know, this is one of the most important predictive factors also for response to PARP inhibitors. So there was a strong selection for a valuable response to platinum. This is not the case in PAOLA-1. 50% of PAOLA-1 patients did not have any residual tumor, so you could not measure the response to platinum. So all patients were included. And so I think that makes a big difference. So the patients I would consider for PARP inhibitor alone are those with a very, very good response to platinum. So how can you measure the response to platinum? You will ask me. And there are several things you can use. The RECIST criteria, which are the usual. The surgical outcome, if you do interval debulking surgery, you can see when you achieve, a complete cytoreduction. The Kalim score, as I mentioned before, and the chemotherapy response score. Why the Kalim score? As you know, there are several I recognize retrospective analysis of Kalim, but it seems that in patients with unfavorable Kalim score, bevacizumab can be more effective or can provide more benefit. So the Kalim score, you need 3 tests done in 100 days, in a period of 100 days, to apply to calculate the Kalim score. So in this population, it means that chemotherapy probably is not extremely effective and bevacizumab can provide a benefit. And so that's something that you can use. The other thing I'm using to decide whether the patient had an optimal response to chemo, platinum chemo, is the CRS, the chemotherapy response score. I don't know your pathologist, but my pathologist is always giving me this CRS, which means CRS 1, response was really not good. 2 is in between, but 3 is very good. Complete or near complete response to chemotherapy. So I use this to identify those patients who have a very, very good response to platinum. This is just several studies looking at the impact of CRS on prognosis, and you can see that with the CRS of 3, these patients are extremely good prognosis, so these are patients responding very well to platinum-based chemotherapy. Now, finally, the other issue that you should discuss is the toxicity and quality of life, and also the patient preference, because of course, if you use olaparib, you just use an oral drug, and if you use the combination, you are also using an IV drug, and this can be more inconvenient for the patient. And as you know, the toxicity profile of, you see here the SOLO-1, the PRIMA, the ATHENA, the PAOLA-1, which are all the options that we have right now. There are differences. Some of the side effects are very common for all PARP inhibitors. For others, there are differences. You know, niraparib particularly for the thrombocytopenia, and leukopenia. For rucaparib, you may have liver toxicity. And for PAOLA-1, of course, you have the added side effects of bevacizumab. There is no synergism, so it's not amplified, but of course, you may have the hypertension, which is typical of bevacizumab, and other side effects which are related to bevacizumab. So you should discuss all of this with your patients for sure. As I said, we don't have direct comparison, but there are trials ongoing. And this is the Nirvana, which is comparing niraparib plus bevacizumab plus or minus bevacizumab in patients without residual tumor. And then AGO study looking again at the combination of niraparib with bevacizumab versus niraparib alone. And this probably will give us a definitive answer whether the addition of bevacizumab really provide a benefit compared to single agent PARP inhibitor. So just to conclude, and I hope I am on time, yes. So let me tell you which are my take-home messages. Maintenance therapy with PARP inhibitors in frontline has changed the natural history of patients with high-grade serous ovarian cancer and genomic instability score positive tumors. BRCA HRD testing is mandatory for patients at treatment selection. Therapeutic management of ovarian cancer in multiple settings has shifted dramatically, with the first line overall survival data from SOLO-1 and PAOLA-1 raising the hope of a potential cure, as I have shown you. The role of bevacizumab added to PARP inhibitor in patients with GIS tumors is still a matter of debate. Clinical characteristics I showed you may not play a major role. Optimal response to chemotherapy may favor PARP inhibitor monotherapy. KLIM score can help select patients with a greater benefit from bevacizumab, but randomized clinical trials are eagerly awaited. And I think also new biomarkers behind BRCA and genomic instability score, such as circulating tumor DNA, are needed to identify patients that will progress on or shortly after PARP inhibitor. So taken together, current evidence highlights the importance of introducing PARP inhibitor as early as possible for eligible patients. And I thank you for your attention.
Thank you very much, doctora Nicoleta. Ahí tenemos espacio para preguntas. No sé si algunos de los participantes en el chat quieran poner sus preguntas o también creo que el doctor Pierre quiere hablar.
Sí, sí, tengo una. Muchas gracias. Dr. Colombo, thank you for your excellent talk. One question I have for you. If you plan to use BEV, what is the most important thing for you? You wait for the test or you wait for KLIM? What is the most important, KLIM or the test?
Yeah. Yes. Okay. As I said, we have this particular situation in Italy. So I wait for the test because if the patient has a BRCA mutation, I cannot use the combination of olaparib and bevacizumab. This is stupid, but in Italy, we don't have the reimbursement for olaparib in combination together, but only for olaparib in the patient with BRCA mutation. So that's why, for me, I wait for the test because if the patient has a BRCA mutation, I will not give her BEV, otherwise I cannot give olaparib, which is the most important drug. Okay, and so this is for me, and so in a way it's easy, but for you probably it's not the same. So what I would do, yes, I usually, let's say for the HRD positive, I wait for the test for sure, but also I'm looking at the KLIM score. So right now I start with chemo alone without BEV. And I try to, particularly in those patients with measurable disease or patients undergoing neoadjuvant chemotherapy, where I can assess the response. So I start with chemo, And then after 3 cycles, I assess the kalim. I assess if she undergoes the interval debulking surgery. I assess the CRS and so on. And at that point, I decide whether to add or not bevacizumab. And so in case the response is okay, but not really outstanding, I would add Bev after surgery, after the interval debulking surgery. And then, of course, if it's HRD positive, I will also add olaparib together. Now, if the patient has primary debulking surgery without residual tumor, I cannot measure the response. I cannot use kalim and so on. So in this situation, if she is HRD positive, I would anyhow consider the combination. If, of course, there is no contraindication for the use of bevacizumab, so I discuss with the patient. If she has not contraindication, I say, look, right now, HRD positive patient, the best we can achieve is the combination, because we also have positive overall survival data. And so I prefer to use the combination in this situation. So that's what I do. When I can assess the response to a chemo, then I wait for the kalim score to decide. I don't know if it's clear.
We have a question in the chat by Dr. Javier Segovia. Even with the results of overall survival with niraparib, do you use niraparib in any population?
Okay, yes, because of the regulatory approval. For instance, if I have HRD negative patients who achieve a complete response to neoadjuvant chemotherapy, so extremely good response to platinum, in this case, I may consider to use niraparib. That's where I would use niraparib single agent. And why I'm saying so, because I want to say something about the test. You have to remember the HRD test is not perfect. So HRD negative does not mean for sure HRD proficient. For sure, there are patients who tested negative at the HRD test, but maybe they are proficient. And that's the reason why in the PRIMA study, you see some benefit in some patients, even if the test was negative. So how to identify these patients? Who are they? I mean, the test is negative, is a false negative, but they are proficient. My way of identifying them is to look at the response to platinum. So the response to platinum for me is the best test to assess if they are really proficient or deficient in the homologous recombination. If they had a very good response to platinum, they are probably deficient. And therefore, even though the test is negative, I will give them niraparib. I don't know if it's clear, because again, I want to pick up the small proportion of patients with HRD negative test, but were not proficient, but are really deficient. And these are the patients who can benefit from the use of PARP inhibitor. The test is not the Bible. There is a lot of, and you see it, for instance, in the Chinese population where they use a different test. Do you remember the test did not discriminate at all the benefit of PARP inhibitor. Why? It's not because of the drug, it's because of the test. The test did not select well the population. So the test is very important, but of course it's not perfect, and we have to keep in mind this when it is negative.
There is another question in the chat. In patients with resistance to platinum, is worth it to use an HIPAR inhibitor in the maintenance is if there is a response with this second line of treatment?
I don't know if I understood correctly. So you're talking about relapse after frontline or in frontline? So platinum resistant relapse.
Yeah, persistent, and you give a second line with doxoliposomal. And if you have response, do you use a PARP inhibitor maintenance after response with this second line of treatment?
So you mean there is a patient with a platinum-resistant relapse. You treat the patient with platinum again, and she responds, and then the question is whether to use PARP inhibitor here. So
No,
you are.
I understand she got a second line without platinum because
Without.
it's
So then, no,
resistant.
why should you use a maintenance with PARP inhibitor? I mean, you use the relapse only after platinum, not after other, there is no indication at all. So only if she responds again to platinum at time of relapse, then you may consider PARP inhibitor if she does not get the PARP inhibitor in front line, because otherwise it's not approved. I mean, it's off label, of course. Somebody is using it based on the real study, but it is actually not approved.
There is a study, is the study the Quara study. Yeah, from Mitza Mansour.
Which one?
Quadra.
It's an
Quadra.
Quadra. Yeah, but this nobody is, there are no guidelines including PARP inhibitor in my personal experience is that in platinum resistant, I mean, maybe rarely, if you have a rare patient with BRCA mutation without having received a PARP inhibitor in front line, then you want to give PARP inhibitor at any cost. Maybe you may consider that, but the response rate is very low. There is also a much bigger study from Ilyas Vergote comparing with chemotherapy, and response rate is very, very low. In my experience, PARP inhibitors do not work in platinum-resistant patients.
I have a question. How do you deal with this patient with BRCA muted, with BRCA mut and a bad response to first line platinum? How you deal with this patient? Or like in Paola 1, we have those patients. We don't respond to platinum in first line. How you do you deal with this?
So patients with BRCA mutation not responding to platinum frontline.
Yes.
Wow, that's terrible. That's really a terrible situation. It's very rare, fortunately. But of course, you are talking about platinum refractory disease, so progressing on PARP. There's nothing to do, really. I mean, you can use the usual drug that we use in second line with a response rate which is extremely low, so Calyx or weekly paclitaxel or stuff like that. Unfortunately, the majority, if not all, the clinical trials exclude this patient. So if the patient has a refractory disease, so progressing during frontline platinum, they are excluded from any clinical trial. So we cannot even offer a clinical trial to these patients, unless it's a phase 1. Maybe sometimes there are phase 1 that may allow these patients, but they are doing so poorly that really there is nothing for them, unfortunately.
I have one question. In a first relapse, a platinum sensitive, and you gave her a platinum and response, and is HRD positive, BRCA wild type. Do you use an PARP inhibitor in this scenario after a first relapse?
Yes, if she did not receive a PARP inhibitor in front line, I mean, yes, of course. No, I'm still using in any platinum sensitive relapse responding to platinum, because as you know, platinum sensitivity is is not a certainty. It's something that we assume. Then you give platinum, and if she responds to platinum, that means that is platinum sensitive. So in this case, yes, you can give a PARP inhibitor as a maintenance, but these patients are becoming more and more rare because the majority of patients are receiving in frontline a PARP inhibitor. Now, there is the ORIO study, as you know, and they looked at the re-challenge with PARP inhibitor. However, most of these patients did not receive PARP inhibitor in front line and then a relapse, but most of these patients had received PARP inhibitor at the first relapse, and then they receive again a PARP inhibitor at the second relapse. So it's not answering completely the question of the re-challenge with PARP inhibitor, but the benefit seen in this trial is very small. So I don't think it is the way to go. So in other words, if the patient had received already a PARP inhibitor, I would not re-challenge with PARP inhibitor again. But there are many trials now planned in this population looking at different PARP inhibitors, new generation PARP inhibitors, or we have a trial, for instance, for patients progressing on PARP inhibitor using different DNA response modulators, such as ATM inhibitors or ATR inhibitors together with PARP inhibitors. So you have to try to overcome the resistance, you know. And so this is a matter of clinical trials now and of course, you know, research. Yeah.
I think we don't have.
I have one. Professor, we know that BRCA2 and BRCA1 perform differently.
Yeah.
Do you decide in patient with BRCA mode the PARP inhibitor on BRCA, if is BRCA1 or BRCA2?
No, no, absolutely no. I don't think we have any reason to choose a different PARP inhibitor for BRCA1 or BRCA2, or the combination versus the single agent, because we don't have any data on that. It's just a matter of prognosis. I mean, the BRCA2 have better prognosis. They live much longer. But many of them will relapse anyhow. So, but it's just different prognosis. I don't think we have any data to support a different use of PARP inhibitors or a different PARP inhibitors or a different combination. I'm just telling the patient that she's lucky because BRCA2 is usually associated with a better prognosis and a longer overall survival. So, but at the end of the day, the treatment is the same for sure. Yeah. Of course, we have to better understand, you know, all this, even the type, as you know, maybe Isabel talked to you about the importance of the type of mutation in BRCA1, because according to the mutation, you may have a more sensitive tumor or less sensitive tumor. So there is a lot of studies going on in this respect to try to identify the best patients. And of course, all the issue of the liquid biopsy to understand if the patient is cured or not, and so to stop the treatment, when to stop the treatment. We have still a lot of questions open, I guess. And also the treatment after resistant to PARP is also a major issue right now. We have to understand how to treat these patients, because we know that they respond to platinum, but not as well as the ones without PARP inhibitors. So we have to understand how to treat this population. Yeah.
Dr. Colombo, thank you very much. It's an honor for us, you having this conversation and sharing this space with us. So thank you very much. Gracias a todos por los que se conectaron. Gracias a Gesigo, gracias a AstraZeneca y nos vemos en una próxima ocasión.
Thank you so much. Thank you.
Thank you, Professor.
Hope to come back again.
See you in Rome.
Okay. Ciao.
Yeah.